That's a possible alternative to reduced cholesterol, which we know contributes to heart disease.
Yes.
However, if you follow the Ornish prescription,
right,
you can reverse heart disease by a low-fat diet. In which you now say not 10% unless you have serious heart disease, but 30% fat is allowable.
No, I'm saying that those drugs are proven to lower cholesterol and in some cases even to reverse heart disease. But like all medications, they have side effects, both known and unknown, and they're expensive. If everyone followed the recommendations that just came out, we'd be spending $30 billion a year to do what most people could do for free if they were simply willing to make bigger changes. Now, not everybody wants to make changes, and I'd be the first to acknowledge that. But I do think that people deserve to have the facts so they can make an informed choice. And if you came to me, I'd say, well, you could go on drugs, that's one approach. If you're willing to make only moderate changes in diet, you'll probably need to be on the medications. If you're willing to make bigger changes in diet and lifestyle, in most cases you can avoid those medications.
Let me stay with that issue. What are big changes in diet that you think would eliminate the need for drugs?
Well, there's a genetic variability in how efficiently your body can metabolize or get rid of fat and cholesterol in your diet, okay? And it's a bell curve, like so many things in biology. On one end of the spectrum are the 95-year-old men and women. You say, what do you eat? And they say, oh, I eat 12 eggs for breakfast and a steak for lunch. And you kind of go, wow, maybe diet's not that important. Look what they're eating and they're 95. Right. But everyone else who was eating that rich a diet and wasn't so efficient at getting rid of their cholesterol never made it to 95. That's who you're left with.
Right.
On the other end of the spectrum are people who have heart disease or high cholesterol. And in general, they are genetically inefficient. They have fewer cholesterol receptors, which is what Brown and Goldstein discovered and got the Nobel Prize for. So if you take somebody who's not very efficient at getting rid of fat and cholesterol, and you only reduce their intake a little, like the government recommends, they're still eating more than their body can get rid of, and so the blockages continue to worsen. Now, the corollary, though, is even if you're on the inefficient end of the spectrum, if you reduce your intake much lower, then you're no longer eating more than your body can get rid of, and then your body can go to work beginning to heal what's been building up in your arteries for all these years. So people have a real choice. Now, if you don't have heart disease, it's not all or nothing. Maybe a moderate diet is enough for preventing disease. You know, the old saying about an ounce of prevention is true. I don't recommend a reversal 10% fat diet for everyone. I recommend a more moderate diet if you don't have heart disease.
In a preferred world, you would like to see everybody on a 10% fat diet.
Not necessarily, no. Not everybody needs to make changes to that degree.
But would they be better off if they did, even though it would be a hard go?
Sure. I think everybody would be better off. Look at Asia. That's the way 4 billion people have been eating for many years, and it's in those countries where heart disease has a fraction of what we have here. Or not only heart disease, but breast cancer in women, prostate cancer, colon cancer, diabetes, hypertension, a wide range of illnesses.
Before I turn to love and intimacy, just walk me through a diet that you think, in terms of what's the composition of 3 meals that would be, in your judgment, in the best interest of your heart.
Well, again, if you don't have heart disease, you don't have to be so strict. But let's say you have heart disease.
Okay.
Then I'd say either you need to be on a strict diet, and not just the diet, but the other parts, or you need to consider going on these cholesterol-lowering drugs. Now,
what's the diet?
The reversal diet is essentially fruits, vegetables, grains, beans, non-fat dairy, soy products. Okay? So it's a whole foods, high complex carbohydrate, very low-fat diet.
Any meats?
There's no meat in the reversal diet.
Right.
And when you go from a meat-based, typical American high-fat diet to a low-fat, plant-based diet, you really get a double benefit. You're not eating those disease-causing substances like cholesterol, saturated fat, oxidants, and so on. But in addition to avoiding those substances when you eat a low-fat, plant-based diet, you're getting at least 1,000 others that are protective, that have anti-cancer, anti-heart disease, and anti-aging properties.
In the strict diet, just stay with me on the 10% fat. No meat, no chicken, no fish. What else?
Well, you can have unlimited amounts of fruits, vegetables, grains, beans. So for breakfast, you could have some cereal with soy milk or non-fat milk, some oatmeal like I had for breakfast this morning. You can have for lunch or dinner, you can have, you know, anything that's in the fruits and vegetables family. You know, you can have a fruit plate, you can have salad, you can have pasta, you can have, you know, there's an abundance of foods out there.
Pasta's okay.
Pasta's okay as long as you eat it with other foods that are high in fiber so that you don't get the insulin response.
Okay.
If you're just eating pasta alone.
High in fiber would be cereals primarily.
Fruits, vegetables, and grains have generally a lot of fiber, as long as you eat whole wheat grains and not the white flour.
And what's the difference in a 10% and a 30% fat intake? What am I allowed now if I move to that level where I don't have heart disease, so you're going to allow me more choices?
Well, that's basically the American Heart Association diet, or the National Cholesterol Education Program diet. It's less red meat, more fish and chicken, 4 eggs a week, et cetera, et cetera.
Prostate cancer. What do you believe about reducing, curing, treatment of prostate cancer?
I believe that we're at the same place with respect to prostate and probably breast and colon cancer that we were 25 years ago when we did our first studies with heart disease. In other words, if you look at the epidemiological data from other countries like Japan, they have a fraction of the prostate cancer that we have in this country, but then when they move here and begin eating and living like we do, it goes up astronomically. The animal data, you can take, Bill Fair has done studies where he'll inject prostate cells into rats, put them on a typical American diet. The tumors grow very quickly. He'll then randomly divide the rats into high and low fat diets, and when they get the diet down what we're talking about in the reversal diet, the tumors stop growing or even shrink, but on the higher fat diet, they just keep getting bigger and bigger. There are anecdotal case reports in humans. So I said, look, 4 years ago, Mike Milken had a nutrition summit, and he said, let's bring together about 6 people who were experts in either nutrition or prostate cancer. And so Bill Fair and Peter Carroll, Peter Carroll's the chair of urology at UCSF, and Bill at the time at Sloan Kettering in New York, and I decided, let's do a study. So we're taking men who have biopsy-proven prostate cancer and who've elected not to get treated, the so-called watchful waiting group. Now you might say, why in the world would a guy who knows he has prostate cancer not get treated?
You took the words out of my mouth.
It's very much like it was with heart disease. I mean, we can come back to heart disease in a moment, but no one has really shown that men, particularly if they're older and they have the less aggressive form of prostate cancer, that the treatments help them live longer or prevent metastases. But they leave many men, if not most men, either impotent or incontinent. And so some men say, why should I put myself through that?
That's surgery. I mean, they also will argue that sometimes that's a consequence or a byproduct of surgery, but other kinds of therapies don't have that impact.
Actually, they do. Whether it's brachytherapy, radiation, cryotherapy, hormonal therapy, they almost all have that impact.
Of incontinence and impotence both.
That's right, particularly impotence.
Then why choose surgery over those, or why choose those therapies over surgery? Because surgery, it is argued by some in this debate about this, is more likely to eliminate all the cancer spreading. Because the problem with prostate cancer, as I understand it, is not in the prostate. It's the fact that it spreads to other parts of the body.
Well, what many people
in the prostate, you could take care of the problem.
What many people don't realize is that even if you have prostate cancer that looks like it was confined to the prostate, and they cut it out surgically, that within 5 years, about 30% have recurred. And
because they didn't get it all, or some other reason?
Because it had already spread microscopically.
Right, exactly, yeah.
Okay, so it's not like...
So
anyway,
nothing is sure.
The point is, we don't get involved in those decisions anyway. Those are decisions that people have made independent of our study. But what it's great from a scientific standpoint is that we find those people, and they're hard to find because there's so many doctors in the San Francisco area that they tend to do things to people. That's another story. But we randomly divide them into two groups. Half of them we ask to make intensive changes in diet and lifestyle, and half of them don't. And then we compare them.
Yeah, those that don't, they're not taking any. Your whole entire sample is not doing any other therapy at all.
Correct. Some of them go on in the course of the year and do it, but most of them don't.
But because the test here is to find out if diet can reduce prostate cancer.
Diet and lifestyle.
And lifestyle.
And it's not just the diet. Our preliminary data are finding that the correlation, the adherence to the support groups in yoga and meditation seems to be having as much of an effect on their PSA as the adherence to the diet.
Tell me what you dream. What do you hope?
I dream of a time in medicine where we can integrate the best of science and technology with the best of the kinds of things that we do, Dr. Rachel Remen and others do, that really address the causes of why people suffer. They're not incompatible, that we give people the full range of options, and we support all of those options. Right now, the irony is that if you want to get a bypass, most insurance companies or Medicare will pay for that, or for an angioplasty. Most insurance companies will pay for a lifetime of drugs. But except for companies like Highmark Blue Cross Blue Shield and Lifestyle Advantage and Mutual of Omaha, very few companies will pay for the kinds of things that we're talking about. I'd like to see it where the full range of options are available to people, where we fund not just a small fraction of the NIH budget on these kinds of issues, where most of it goes to molecular biology, which is important, but it's also important that we deal with these issues, that we have more science to show how powerful these changes can be in people's lives and what a difference they can make. That's my dream.
Thank you. Dean Ornish in Aspen, back in a moment. Stay with us. Dr. Rachel Remen is a physician, and she's also one of the most recognized pioneers of mind-body medicine. She started out as a pediatric endocrinologist poised for a successful academic career at Stanford Medical School. But she discovered that something was missing from the traditional practice of medicine. Since then, as the founder of the Commonwealth Cancer Health Program, the author of 2 best-selling books, and in frequent public appearances, she has helped to redefine the way medicine is practiced. I am very, very pleased to have her here on this program from Aspen. Tell me about this journey that you took. You dreamed of being head of the pediatric department.
Mm-hmm. Come from a family of doctors. In 2 generations in my family, there are 9 doctors. And so I was the only pre-med in kindergarten.
Yeah.
You know?
Right.
And I had my life path all set out.
Pre-med in kindergarten.
Yes. I had my life path all set out. I was going to be the first woman to head a department of pediatrics on the West Coast.
Yeah,
that was my ambition.
Right.
Yeah.
And so what happened? You went to Esalen or somewhere, and they showed you a world that you didn't know?
Well, you know, you can always tell the moment that your whole life changes. You remember it. And my opposite number at Stanford came into my office, the man who ran the medicine clinic, and he put down a bunch of colored papers, and he told me about this thing that was happening at Esalen, where they wanted 12 credible doctors to go down there and look at the human potential movement and see if it had anything to do with health or illness or the recovery from disease. 1972.
Do we have anything to learn from those crazies down at
Exactly.
Right.
And I looked at the pieces of paper, and I heard about what Esalen Institute was. I had never heard of it. And I worked and lived 2 hours north of this revolution in thinking, right? And I remember the first thought that went through my head, what a great way to meet men.
All right, Rachel.
So I went. You know, I think the soul is very crafty. I think the soul takes us by whatever handle is sticking out and brings us along our life path. Because if I knew that I would have to give up pediatrics, and I would have to give up the respect of my colleagues for years, I would never go down there. No, no.
So you went down there.
Yes.
So what did you see, hear, feel, experience that made you go back to Stanford and say, I'm out of here?
Well, I had been a philosophy major. I almost didn't get into medical school because it was seen as an irrelevant major for a doctor. Right? It's probably one of the best majors imaginable.
Philosophy.
Yeah, for a doctor.
Why is that?
Well, because a lot of medicine is about philosophy. It's about what's important and helping people find what's important in their lives. It's not necessarily biological repair. And so in going down there were all these new ideas of what a human being is. That a human being was more than their body. And that it was possible even to have, there was a healthy way to have a disease. There was a way to be ill or have a serious illness such that as a human being, you became deeper, more compassionate, wiser. Right? Now, I myself had been interested in this for years because I have a severe chronic illness.
Right, which is?
Crohn's disease.
Which means?
Disease of the intestine, of the joints. Nobody knows what causes it. There's no cure for it. And I've had it for 48 years. And as my body struggled with this disease, I could feel something different happening to me as a human being. I could feel that I was changing in a way that made me equal to this disease, in a way that was going to enable me to live beyond this disease, even though it would never be cured. And you know, I could sense that in my patients, but I never knew how to access it. I never knew how to make it into a resource for people. And at Esalen, I began to learn this. And it was very important.
So what Esalen did for you was in part because you had Crohn's disease, in part. So what did you do then after you left Esalen?
I left Stanford.
Yeah, I left Stanford too, right.
Yes. And you know, I had
deciding that your mission was what?
that somehow there was a difference between curing and healing, and that we had focused our